So it's fantastic to be here to celebrate the 30th birthday of the HRB. And I was tasked with making this pertinent and relevant and really focusing on what the HRB has done for us. So, as Graham said, I direct the Infant Centre, and rather than go into a long explanation of what we do, we've got a 1.5 minute infographic which just summarises why we do what we do and what we do very briefly. Can you play the VT, please? Thanks. And there is more user-friendly information like that on our website. So underlying what we do, and actually pertinent to the previous talk, which was amazing, is a little known fact, and that's that perinatal complications, things that happen during pregnancy or in the first few weeks of an infant's life, actually account for 10% of the global disease burden. And yet R&D investment over many decades in the perinatal healthcare space has been small and non-strategic, and there's a variety of reasons for that, and today is not the day to explore them. But it is true that equitable investment in perinatal healthcare could avert about 3% of the global disease burden within a decade. And that's really our raison d'etre. It's why we get out of bed in the morning and do what we do in the Infant Centre. And I'd like to illustrate what investment can do in our space with two case studies, both of which originated in the HRB's investment in our research. So my first Health Research Board Award was back in 2007. In 2006, when I moved back to Ireland, I applied to the newly established Clinician Scientist Award Scheme and was one of the first clinician scientists to be awarded a programme grant. I had 1.6 million for a 5-year programme grant to establish a longitudinal pregnancy cohort study called SCOPE, and many people in the audience will have seen data arising from this study over the last decade. It's a large international cohort study of low-risk first-time mothers, and the primary aim of the study was to develop screening tests for late pregnancy complications, particularly preeclampsia and preterm birth. But it's generated an enormous quantity of data which is relevant to our healthcare system. Between 2008 and 2011, 1,700 first-time pregnant Irish women joined over 4,000 women from New Zealand, Australia, and the UK to form this international cohort. More can be found out about the study on the website, www.scopestudy.net, which details all the protocols, the methods, and the significant number of publications that have arisen, which now number over 100. We've had more than 100 peer-reviewed scientific papers arising from this study, including the first clinical risk prediction algorithm for preeclampsia. We've also published the American Heart Association paper of the year last year, looking at early pregnancy screening for preeclampsia, combining biomarkers with clinical risk data. Interestingly, and very pertinent to today, that €1.6 million investment has actually led to us enable us to leverage another 30 million euro in follow-on funding, 14 million of which was in Ireland and almost all of it non-exchequer, which shows how we can return on investment in key strategic areas. Some of that funding established the Cork Baseline Birth Cohort, which is Ireland's first and only birth cohort. These children are now 5, and they're providing fascinating insights into childhood obesity epidemic and other very pertinent healthcare issues. We've had 8 patents granted, some of which actually pertain to a prototype screening test, 2 screening tests for the early prediction of preeclampsia, and they're both now in phase 2A clinical trials. Those trials will report next year, and with luck we'll be taking one of these tests to the clinic and to the market in Q4 2018. So it's a really exciting time, and I think a fantastic success story. I'd now like to move on to our second case study. This baby in the picture here was born early as a result of fetal growth restriction. This is a common condition. It's what keeps me busy during the clinical days and often during the nights. It affects about 3% of pregnancies in its severest form, and it essentially leads to fetal malnutrition and hypoxia in the womb. It's currently untreatable in utero. As an obstetrician, my sole task is to time the delivery optimally so that we actually deliver the baby in as mature a fashion as possible and before the in utero environment deteriorates to such a point that it causes stillbirth. And for me, I then pass the problem on to my neonatology colleagues. These babies often are on the NICU for many, many weeks and sometimes months. And babies that do survive are at significant risk of all the complications associated with prematurity and all the morbidity that occurs secondary to critical fetal hypoxia. And there's a lifetime legacy. These babies often turn up in the cardiovascular clinic with cardiovascular disease, type 2 diabetes and hypertension in their 4th or 5th decade of life. We know that fetal growth restriction is caused by poor placentation. Babies that become growth restricted, the placenta doesn't form early in pregnancy, and as a consequence, the spiral arteries retain their endothelial lining, and they're very small and have a high resistance, low capacitance circulation. And very simply put, a small placenta equals a small baby. That's led us to actually look at pharmaceutical ways that we might actually counter this. Sildenafil citrate, better known as Viagra, is a potent vasodilator of the genital tract, and that's why it first shot to prominence as a lifestyle drug for erectile dysfunction. But a long time ago now, we actually realized that it might have some crossover effect and actually improve placental blood flow, and consequently actually improve gaseous and nutrient exchange in the placenta. Over 10 years ago now, we started extensive animal and in utero human studies, which have all supported this concept. And there are now over 50 papers of ex vivo and in vitro studies showing that phosphodiesterase inhibitors improve placental blood flow, and in a variety of animal models improve pup weight and birth outcomes. So just very recently, we've actually taken this to a very novel, exciting clinical trial. Strider Island is coordinated by Infant. It's funded by the HRB, and it's a randomized placebo-controlled trial of sildenafil citrate for the treatment of early onset IUGR. It's going to be the first trial of our newly funded HRB perinatal clinical trial network. We're going to randomize 112 women with effective pregnancies throughout the 4 main leading maternity units in Ireland. But one of the really good things about this particular trial is its international angle. As a mother, I would not want to know particularly whether my critically growth-restricted baby is going to be born 50 grams heavier. What I really want to know is, will my baby grow up and go to normal school? And answering that question is really difficult because of statistical power. Strider has been designed to actually integrate with 4 other current trials that are recruiting in New Zealand, the UK, the Netherlands and Canada. And the HRB investment has allowed Ireland to take our role in that international consortium. We'll have over 500 participants, and the Global Strider Consortium, which has a pre-planned IPD, will uniquely be able to address that question as to whether this first-in-woman therapy for fetal growth restriction doesn't just improve survival, but does it actually improve neurocognitive outcomes at the age of 5. It's a really exciting trial. The consortium itself is really novel. The whole methodology around a pre-planned IPD is really exciting. There are many, many challenges between now and getting the trial up and running and launched, because it's obviously a high-risk trial in pregnancy, but the investment of the HRB has been absolutely crucial, and I think it's appropriate on the 30th birthday to highlight this very significant investment. So I'll wrap it up there and take questions later with the panel. Thank you.
Thanks.